I'm Dr. Krishnadas Nair, one of the specialist orthopedic surgeons working at NMC Specialty Hospital, Nahda. I've been, after my post-graduation, I've been trained in UK especially for hip and knee joint replacements, and I've been extensively trained at two major internationally renowned hospitals, one at Wrightington and one at Robert Jones Agnes Hunt Hospital, Oswestry, under the mentorship of excellent teachers who are world-renowned hip and knee joint replacement surgeons. I take this opportunity to introduce all friends to the topic of hip and knee joint replacements, and mainly the indications, the possible complications and the advantages of doing it. And in the meantime, I will also try and answer most of the queries that come through the WhatsApp. So starting with hip and knee replacement surgery. The main indication for joint replacement surgery is arthritis in the joint, that is loss of the cartilage covering the bone ends, especially the knee and the hip. The reasons most commonly are osteoarthritis, then rheumatoid arthritis. In the hip it is avascular necrosis, and this tends to happen in younger age group as well, especially those who are taking alcohol or those who are on steroids for other connective tissue disorders or asthma on long term are prone to get avascular necrosis of the hip. So what are the indications? So a few questions have come through now. So first question is regarding what is the right time for doing a hip replacement surgery. So the best time to do the hip replacement surgery is when the patient is in terrible pain, and once we have tried all the conservative measures. What do we mean by conservative measures? It is oral anti-inflammatory medications, non-steroidal anti-inflammatory drugs, or painkillers in common man's terms. If the person is on painkillers for a long time and is not getting any relief from the same, if the pain is too disturbing and it is interrupting his sleep and it is interfering with his day-to-day activities, and thereby the quality of life for the patient is affected. So this is the best time to consider that this person is likely to benefit from a hip joint replacement. And before that, we can also try a few sessions of physiotherapy. This may give some benefit. And ultimately, when there is no answer, hip joint replacement is the best solution. Hip replacement surgery is known as the operation of the century because it has given a good success result of 95 to 98% pain relief, improvement in quality of life for the patient. So next question is, what are the aims of a total hip replacement? What are the goals? So number one goal is to alleviate or relieve the patient from pain that is affecting his quality of life. Second is to improve his mobility or the way he walks. If he's really struggling with the mobility issue and he's really using some walking aids, then we can definitely improve this by doing a total hip replacement. And definitely the range of motion. Stiffness is a big problem in arthritis and also in avascular necrosis, especially rotations get affected. The patient is not able to rotate his hip, neither is able to take his hip to the side. It becomes extremely difficult for the person to mobilize. This hip replacement surgery will definitely help this patient to improve his overall standards or quality of life. Next question is from one of the colleagues is, what is hip replacement surgery? So hip replacement surgery is a major surgery. It involves, so I have a few models with me with which I can demonstrate what exactly is being done during the operation. So this is a normal femur or thigh bone. It's the longest bone in the body. And in hip joint arthritis, it's the femur head that is getting affected. That is this part. So it is this globular structure or the spherical head that is articulating or joining, or it's congruent with this socket. Socket is quite small in this model, but this is just for demonstration purpose. So it is the femur head that rotates freely in the hip joint socket, and if there is loss of bone, loss of cartilage at the end of this bone or in the acetabular socket, this leads to arthritis. The surrounding muscles and ligaments tend to become contracted and stiff, and that adds to the pain and stiffness of the patient. So in hip replacement, in total hip replacement, what we do is take off the diseased part of the femur head, resect it at this level, and replace it with a metal stem followed by a metallic ball, and on top of that there will be a plastic cover. That's a polyethylene shell. The polyethylene shell with the metal ball, metal socket will go inside the acetabular cavity. So that will lead to complete hip joint replacement surgery. So next question is, what are the different designs and surfaces of hip replacement surgery? So there are different designs that are available. So there are different, that depends on what surface is going to articulate. So it can be a metal on metal hip, which is not used nowadays because of high risk of complications. So it is sort of not that fruitful surgery, or it's not favorable for the patient to do this. So now the choice of implant is metal on poly, that is metal head with a polyethylene socket, or a ceramic on ceramic, that is a ceramic head with a ceramic socket. And there are different types of stem that is available. That is, one is the uncemented stem, that is, the femur stem is uncemented, where we don't use any cement, and the bone of the patient itself grows into the femur stem and holds it in place. So this takes roughly 6 to 8 weeks time for the bone ingrowth to happen. So that's the uncemented stem. The other stem is the cemented stem, where we don't expect that the patient is having good bone quality, especially in older frail patients where the bone ingrowth capacity is not that great. In these patients, additional cement is inbuilt, or we introduce cement in between the stem and the bone, so that it acts as a grout to hold the stem in place, and it becomes, so the cement stem and the host bone becomes one complete structure. So these are different types of stem. Similarly, we have different types of acetabular sockets. One is the uncemented socket and the other one is the cemented socket. So again, it depends on what's the host bone quality and is it reliable. Especially in a younger patient, always prefer to do a uncemented acetabular socket, because we rely on the host bone to grow into the socket and hold it in place. Next, already discussed question is the benefits of the total hip replacement. So total hip replacement surgery is the overall, we can say it's the most satisfying surgery for the patient and the surgeon, because 95 to 99% there is pain relief, better quality of life, improved range of motion of the hip joint. So it's definitely a satisfying surgery. Next is, what are the risks and possible complications of the surgery? Of course, total hip replacement is a major surgery. It has its risks, which need to be discussed in details with the patient before undergoing the surgery. General risks are in the form of stroke, MI, that is myocardial infarction, and in worst cases it can be death as well. But these are in very elderly and frail patients who are having severe comorbidities like heart conditions, uncontrolled diabetes, and a previous history of stroke. So these patients are definitely at high risk, and these all need to be assessed before the surgery and made sure that the patient is entirely fit before going in for such a major undertaking. The other risks are risks related to the surgery itself, like infection. The risk is lower nowadays because of the use of good intravascular antibiotics, IV antibiotics that are given, and also with the improved surgical techniques and the sterility in the operation theatre itself. So we maintain high standards of sterility at our hospital, and our operation theatres are clean and safe for the patient. And we also make sure that the appropriate antibiotic is given 15 minutes before the surgical incision is put on the patient, and also post-operatively. And the next risk is there of bleeding. So we take due measures to control the bleeding intraoperatively, but sometimes there can be bleeding which needs blood transfusion to the patient postoperatively. Most of the times bleeding is controlled with the use of special instruments called cautery, and also by the hypotensive anesthesia, that is the anesthetic technique. So the bleeding is pretty well in control and it doesn't cause much of a trouble most often. The next risk is there of dislocation. Dislocation is a dreadful or not that great complication to happen, and this depends on the way the implant is put in. Also it depends on the host factors, how the patient has followed the post-operative instructions. So there are certain do's and don'ts after the surgery which need to be followed by the patient, and which need to be explained to the patient in details, what to do and what not to do after surgery. This is very much clear after the surgery. This is very much cleared in the patient's mind. Everything is explained in detail, how to sit, how to stand, and how to not to sit cross-legged after a surgery, after a hip replacement surgery. This will be explained to you in details before the surgery. The next risk is there of implant loosening. Implant loosening is not something that happens straight away. It happens maybe 10 to 15 years down the line after a total hip replacement, and the most common cause for this is aseptic loosening. Aseptic means, the term means it is devoid of infection. The loosening is not happening due to infection. The loosening is happening due to wear of the implant. So every implant, it's not your natural bone. It's something that has been put from outside. So it has a certain duration or lifespan for that particular implant that we are putting in. So roughly, from the National Joint Registries and various research activities that are conducted elsewhere, the common conclusion is roughly 15 to 20 years, depending on the way the patient handles the implant himself. So there are certain activities which need to be completely stopped, especially jumping, running and jogging activities, to keep the implant lifespan longer. But routine walking, swimming and other cycling activities can be continued. It doesn't hamper the implant's lifespan. There is another risk of deep vein thrombosis and pulmonary embolism. These are pretty bad complications to happen, and we take every due precaution to avoid these precautions by the use of foot pumps and also anticoagulants. So these are medicines. Anticoagulants are medicines that are blood thinners. These can be either injectable or oral. So we have both options available for the patient, and this need to be taken for a period of roughly 6 weeks after surgery. And in addition to that, earlier mobilization of the patient is quite important, and we make every attempt to make sure that the patient starts walking the next day after surgery with the help of physiotherapy and walking aids. So the next question is definitely linked to this, and it's regarding getting mobile post-op. So that is when can the patient start walking? That's a very important question to answer. So after a hip replacement, ideally the next day the patient should start walking, if it has been done well and the patient is cooperative and the physiotherapist is great. So it's a team approach actually, and once that happens, we can get you walking the very next day. Starting, maybe we have to use walker frame. That is walker frame is something with 4 landing sticks and a support beam on top. So that helps to walk at the start. Maybe in a week or 2 we can convert to crutch. Maybe 2 crutches at the start and later on 1 crutch. But approximately by the end of 4 to 6 weeks, you should be walking without the help of any walking aids. Next is return to normal life. Next question is regarding return to normal life. This is a major hip replacement is a major surgery, and we do each and every step is very important, right from the start, from before the surgery till the end, and even the post-operative rehabilitation or the physiotherapy. So it's a combined effort of many people that help you to get back to normal life, and this roughly takes around 12 to 18 months and can be extended to 2 years to feel that this new hip belongs to yourself, because this is something foreign or something put from outside. It doesn't belong to your body, but it takes time to get accustomed and feel that it's part of your normal bone. last question that my colleague is asking, that my friend is asking, is about aeroplane travel. So flight travels, ideally after any lower limb replacement surgery, be it hip or knee, should be restricted for a minimum of 3 months. Again, the risk is there of high risk of deep vein thrombosis or clots in the leg veins, and the next risk is of pulmonary embolism or the clots from the legs traveling into your lungs. So these are dreadful complications to happen, and flight travel, because of the sitting position and the long haul flights, especially those flights which are more than 4 hours duration, need to be avoided by the patient for minimum 3 months. And in the meantime, we are also covering you with anticoagulant medications or blood thinners to minimize the risk of deep vein thrombosis and pulmonary embolism. So these were the questions related to hip replacement surgery, and there were a few questions for knee replacement surgery as well. Most of the questions are quite common for both, except for the designs and types of knee replacement. So when is the knee replacement to be performed? When the patient is really, again the same answers, when the patient is suffering very badly, he is not able to sleep well, the pain is so disturbing that he can't walk normally, there is a limp, there is a painful limp, and none of the non-operative measures have helped this person. So definitely he needs a knee replacement, and the minimum investigation we do is a knee x-ray to look for the alignment of the knee, the deformity in the knee, how it looks on the x-ray, the status of the knee joint, that is the tibiofemoral knee joint, that is this one, that is a joint between the femur and the tibia, and the status between the kneecap, that is the patella and the femur. So this the total knee replacement actually entails the replacement of all the 3 components, the femur component, the tibial component, and the patellar component. So there are surgeons who would suggest that just the kneecap need not be really replaced always, but I feel that the patellar replacement does well for the patient, because it takes care of the patellofemoral arthritis or the front of the knee pain as well. That is taken care of at the same time. So I usually go for a complete knee replacement. So the designs or types of knee replacement. Most of the knee replacement that we do are cemented knee replacements. It's not like the hip. Uncemented knee replacements are available as well, but cement is always implanted so that the process is in good fit. And the types of knee replacement, there are different designs from different companies, but the standard of the knee replacement surgery remains the same. The steps remain the same all throughout. Basically 2 different varieties are available, at the cruciate retaining and the cruciate substituting knee replacements, the details of which can be discussed with the patient individually depending on the individual's need and the knee anatomy. The further details can be discussed when the patient is in front in the clinic. The benefits of knee replacement is, again, pain relief, to remove the stiffness in the knee, to improve the mobility of the patient, to give a better quality of life. I always perform an Oxford knee score before the surgery. This is like a functional score to find out how much the patient is suffering from the knee pain and the knee deformity. So to conclude, the hip and knee replacements are both are very good surgeries to perform, especially if it's a clear indication for doing the same and the patient is suffering from pain and stiffness. And definitely this will provide a good quality of life and great improvement for the patient post-operatively, and improve the standards of living and the way he walks especially, and the mobility of the patient. So further details we can discuss when I see the patient in person in the clinic. Thank you very much.